um, comments, we will move to the next person on our list, which is in person over here, Gretchen Rafa. Gretchen, thank you so much for your patience with us, and thank you for allowing another person to come in ahead of you. You're welcome.
Thank you. Thank you, Senator Anwar. Representative McCarthy Vahey, Senator Summers, Representative Claritas Ditria. My name is Gretchen Rafa, and honorable members of the committee. Sorry, it's been a long day for you and me. Testifying, I'm the Vice President of Public Policy Advocacy and Organizing with Planned Parenthood, testifying in support of Senate Bill 986, an act protecting maternal health as the state's largest provider of sexual and reproductive health care to over 50,000 patients at 14 health centers across the state. We believe all people should have access to quality, affordable health care as a basic human right, regardless of who you are, where you live, your income, if you have health insurance, or your immigration status. We thank the Lamont administration for prioritizing maternal health this legislative session. As you are all aware and have heard today, we are facing a maternal health crisis in our state, including the request for labor and delivery closures in several hospitals in our state and persistent racial and ethnic disparities in maternal health and birth outcomes. We are a proud member of the Doulas for Connecticut Coalition, which is led by doulas from across the state. And we thank this committee for taking action over the past 2 sessions to ensure that doulas in our state have title protection by defining doula in statute and then establishing the Doula Advisory Committee within the Department of Public Health to develop recommendations for requirements for certification and certification renewals for doulas. SB 986 offers an important policy intervention that can help address the health outcomes for Black birthing people and birthing people of color in our state. Our maternity care system is failing communities who are most impacted by the burden of structural inequities due to this country's legacy of racism and other forms of discrimination, including for Black, Indigenous, people of color, people in rural communities, and people with low incomes. The United States has the highest rate of pregnancy or child-related deaths in the developed world, and Black women are 3 to 4 times as likely to die from pregnancy-related causes as their white counterparts. Maternal deaths increased by 40% during the pandemic. Doulas and the care, support, and advocacy they provide are one way to improve these outcomes. That's why we need equitable access to doula care in our state. This is an urgent racial justice and reproductive justice issue. SB 986 will establish the voluntary certification process that will increase the visibility and recognition of the profession, establish more sustainable funding options for doulas, expand the use of doulas across the state, and improve integration of doulas into the health system and a part of the birthing person's team. Furthermore, a certification process that centers the voices of doulas and those with lived experience throughout the process and ensure equitable access to certification for all doulas who wish to become state certified. PPS&E commends the efforts of the Department of Public Health and the Doula Advisory Committee, which are reflected in SB 986, and we respectfully offer the same recommendations for amendments to Section 10 as noted in our written testimony and by Cynthia Hayes earlier today. And we also support other proposals in SB 986 that will support maternal and infant health, including allowing for the licensure category of birth centers in our state, universal newborn nurse home visiting services, and an evidence-based infant mortality review committee. We have long fought for a person's right to control their reproductive lives. That includes planning their family, having a healthy pregnancy, giving birth to a healthy child, and raising their family in safe and healthy environments. We will continue to fight for policies that protect the rights for all people to ensure our patients and communities have the resources they need to live healthy and self-determined lives, and fight for a world where every individual's personal decision about their pregnancy is respected and valued. We urge this committee to support SB 986 and take another important step in addressing health inequities in our state and making maternal health a priority. Thank you so much for your time and consideration of this critical legislation.
Thank you so much, Gretchen, for your testimony and staying within the exact 3 minutes by like maybe 2 seconds. I don't know how you did that.
I never do that.
It's pretty good.
Thank you.
We'll bank those 2 seconds for next testimony. A quick question. Is it possible to get a curriculum of the doulas that you foresee, or even the advisory committee, if they have a curriculum of any kind that is there?
Yes, well, I think I don't want to speak on behalf of the different doula programs in the state, because I know the doula training programs might look different depending on what a person wants to specialize, because there's large range of doulas, not just for pregnancy-related care, but what is happening within the Department of Public Health and the Doula Advisory Committee that's already been established. Core competencies have been built by the Doula Advisory Committee and will be ready to go when certification launches in October 2023. So I think I'm addressing your question, Senator Anwar, but the competencies. Wow, the struggle continues to be real for me in this committee. The core competencies will be reviewed by DPH and the doula training review committee. So there's already a process that's being put in place. Continuing education will also be required and be reviewed by the committee and DPH, and renewal for the doulas will be every 3 years. And I know Samantha Liu from Health Equity Solutions is testifying after me. So if I said anything incorrectly, she can answer more questions about that.
Perfect. We just want to be aware of what's the behind the scenes knowledge and information, as if somebody was to ask us the question, at least the committee would have that information, but appreciate your answer. It's
Yeah,
very helpful. I know my co-chair has a question or a comment. Madam Co-chair.
Thank you, McCarthy, Vahey, and McCarty. We're at it again. I thank you, Gretchen, and you had a lot to say in that short time, and I'll ask what Rep. Claridis Ditria always asks, which is, did you submit written testimony or will you be?
yes, hopefully it's online, but if it's not, it should be. I submitted it a little late.
Great, no problem.
Okay.
I think you had a lot of very substantive things to say. And one of the things that I was scrolling to look for was something that you said about COVID and the increases in, I just want to go back to what that was. I believe it was maternal
Yes.
mortality. And if you could just take us back to that and
Yep.
repeat that, I would
So
appreciate it.
the most recent data, and this came out of a report from the U.S. Government Accountability Office on Maternal Health. And one of the things, sorry, now I'm scrolling back to my notes. And I know y'all want to go home.
No, it's okay. We want to hear this too. So
It
I appreciate that.
was,
We live here.
it
so
was, I know. Maternal death increased by 40% during the pandemic. And that study found that it increased overall for Black, white, and Hispanic women during the pandemic.
Thank you. I thought
And that's
what
kind
I
of a
heard.
shocking number.
That's, yeah, and I'm going to admit, I didn't hear as well after you said that. I got stuck there. That's what I thought you said, and that's very significant. I
Yeah.
think we've had a lot of good conversation here today
Yeah.
about what needs to be done, and I appreciate the work that you've been doing with the doulas, and hopefully we can bring the lactation consultants into this conversation
Absolutely.
over time as well. But thank you very much, Mr. Chair.
Thank you. Seeing no other questions or comments, we want to thank you for your patience
Thank
and
you.
being here. Oh, we do have a question. Representative McCarty.
No, it's fine because you did approach the same question. I was just going to ask how in-depth was the certification training, and were there 2 tracks for the doulas, a voluntary certification or not? Maybe you could just explain that. And then I appreciate Senator Anwar looking to learn a little bit more about the curriculum. I don't think right now this is such an important issue, and that we see where we rank in the industrialized nations. I think it's important that we do something serious about looking at maternal health. But I'm just curious, will we still have certified and non-certified doulas?
Yes, so all certification will be voluntary. You know, 2 tracks, 1 through training and 1 through experience. And again, you're going to hear from my colleague Samantha Liu from Health Equity Solutions, who's been working closely with DPH and the Doula Advisory Committee too. That might be able to provide a little bit more in depth. You know, not all doulas, like in our state, might choose to go through the state certification process, and some might not. But this is, again, gives doulas an option to also set up a more equitable system for them as well to be reimbursed. And this is, you know, a path to hopefully private and public health insurance coverage for doulas as well. And then the link to the study should be in my testimony. from the Government Accountability Office, which will outline the numbers, because I think the number went from like around 700 deaths per year in the United States, approximately 700 deaths per year, to I think about over 860. And I do want to just name again that this is a conversation, and when we are talking about reproductive health care too, we have to be talking about the full spectrum, including maternal health. And this is an urgent issue in our state. And we can't separate that conversation from certain parts of reproductive health care.
Thank you. Thank you.
Thank you so much. Seeing no other questions or comments, we want to thank you.
Thank
Please
you.
go home safely.
Thank you so much.
You're welcome. Next online is Amy Romano. Ms. Romano, you're on. Welcome. And thank you for your patience with us. You can unmute yourself and turn your camera on.
Hi, sorry about that. Give me just a moment.
There you are. Welcome.
Hi, good afternoon. Good evening, chairs and distinguished members of the Public Health Committee. My name is Amy Romano. I'm the CEO and founder of Primary Maternity Care. We're a service design and consulting firm based in Milford. Our mission is to enable integrated high-quality reproductive and perinatal care by strengthening systems for community-based care delivery. We have deep experience in evidence-based care models that improve outcomes and equity and reduce costs. These models include midwifery care, birth centers, group visits, doulas, home visits, integrated behavioral health, and digital tools for health and wellness. I'm here to express my strong support for SB 986 and Act Protecting Maternal Health. All 5 of the bill's provisions are critical to addressing troubling trends in Connecticut, including persistent racial and ethnic disparities in perinatal outcomes and recent and expected closures of maternity services around the state. As a well-known leader in the birth center movement and as a consultant to the Department of Social Services focused on operationalizing the state's plan to reimburse for doula services, I want to focus my remarks on the birth center and doula provisions of the bill. I've been a midwife for 20 years, during which time I've practiced clinically here in Connecticut, taught, conducted research, and served in a number of leadership roles. I've been involved in leading and operating birth centers in 6 states and internationally, and authored multiple direction-setting resources aimed at enabling growth of this evidence-based care model that has been proven time and time again to produce positive health outcomes at lower costs to the system. Links to these resources, which address best practices in regulation, payment, quality management, and health system integration, are available in my written testimony. I also led a successful effort to rapidly and safely open a freestanding birth center in Manhattan in the first wave of the COVID-19 pandemic. Thanks to a temporary easing of the long entrenched regulatory requirements, including waiving the costly certificate of need process, we were able to rapidly provide a safe option for birthing people when hospitals were initially overwhelmed. The last time anyone had opened a birth center in New York City, the process had taken 7 years. In the spring of 2020, we did it in 7 weeks. Freestanding birth centers are a high-value, evidence-based model of care backed by federal research and recognized by all major system stakeholders. Connecticut is one of just 13 states without birth center-specific licensure and regulation. Existing maternity hospital regulations restrict the ability to open and operate a midwifery model birth center for low-risk birth. Now is the time to introduce sensible regulations aligned with national standards to help Connecticut safely expand access to the birth center model and to achieve its top priorities in maternal and child health. These priorities, which birth centers have been proven to improve, include improving birth outcomes and equity, protecting community-based access and restoring consumer choice in the face of maternity closures and growing hospital consolidation, enabling high-value care options to rein in costs, and staying prepared for pandemics and other emergencies. In 2021, my team at Primary Maternity Care partnered with the American Association of Birth Centers with funding from the Yellow Chair Foundation to conduct a 50-state review of birth center licensure approaches and to draft model regulatory language for states to adopt. These model regulations and implementation resources are available through the AABC website as a best practice and birth center regulations toolkit.
Excuse me, Ms. Romano, but your time is up. Thank you.
Okay. Sorry, hopefully I can address some of the factors in question and answer.
Thank you so much. We appreciate your being here. Could you just tell me about the international sites that you have, just out of curiosity?
I have worked many years ago. I worked with a birth center in Guatemala that was developed to both provide an option for low-risk people and also provide a training site for community midwives that did home birth and needed referral pathways into a more sort of integrated, respectful model of care. And then I've been just involved in the research side of things and am pretty familiar with how birth centers have been implemented in models like the UK and the Netherlands.
Okay, thank you so much. And do you have a collaborative relationship with the hospitals in other sites, in other states?
Yeah, so I had worked with the largest effort to date to scale up this model of care. It was an investor-funded initiative where we partnered in joint venture partnerships with different health systems. So my experience in the birth center model has been mostly in highly integrated and sort of working toward value-based care design and sort of integrated levels of care across the risk spectrum. We have a new toolkit that we just developed at PMC with partners at the Purchaser Business Group on Health. That's a hospital guide to integrating the freestanding birth center model. There's, basic stuff like maintaining safety and coordination across the risk spectrum, but there's also lots of opportunities for deeper collaboration that hospitals around the country are, exploring, and that we've seen some interesting models emerge.
Good. I appreciate your testimony, and I know my co-chair, Representative McCarthy-Vahey, has a question or comment.
Thank you so much. I think you're going to get the McCarthy-Vahey treatment too. Thank you so much for your testimony tonight and for the information you've provided. Given your experience with this in so many different states, I think you said 6 different states, and you're in support of the bill, I'm wondering if there are things that you might add, right? We know we want to get things started, but is there anything in particular? And I haven't seen your testimony online quite yet, so we'll make sure to look for that because it sounds like you have submitted written testimony.
I'll push submit as soon as I finish this. I apologize. I was putting the touches on it.
I apologize. I think I misunderstood. Thank you. If Rep. Claritas DiTrio was here, she would be asking you that as well. So I'm glad that will be a helpful resource to us. But, is there anything, because I don't think you specifically said that, I think you were talking about the benefits of doing this, but is there anything you might like to suggest to us that we add to what we're doing here?
I think it's a really robust bill. I think if it's passed in the current form, it's really strong and would result in the appropriate growth of access to this model of care. There are a couple of things I want to make sure stay in the various negotiations. I think the certificate of need waiver is critical. There's very clear evidence from other states and around the country that alone is the biggest access barrier to growing birth centers in states that otherwise have the demand and other factors that should make them succeed. And really the alignment with the accreditation process. So what we're seeing in places that have had successful regulation is aligning with the national standards and the accreditation process that goes with that, which is what we see in this bill, the Commission for the Accreditation of Birth Centers. So I think that really addresses a lot of the concerns that we've heard from some of the testimony today about, what does this really look like? What about staffing? What about facility, infection requirements? All of that is covered in existing national accreditation pathways, and for the state to really try to just leverage that rather than try to reinvent the wheel is the most efficient pathway to regulation. I did have a couple of things I would like to see adjusted. One is the fee, the licensing fee, because the licensure would be contingent on accreditation, which also has a fee. The combination in particular is would be very challenging. These are small enterprises. They are small businesses, low volume. The whole model of care works because it's kind of low volume and more individualized. And so these are not large enterprises that are doing this that can afford thousands of dollars in fees. That was the main change. And also this bill would sunset the maternity hospital regulations, which I think we should just pause before we do that. I think speaking of other countries, it's much more common to see freestanding maternity hospitals in other countries than it is here. And we're sort of unique to have a framework to explore that as an opportunity to address the maternity deserts that are forming. So I wouldn't want to close that door without making sure we're doing that with intention. And there's some interesting models. Texas is one of them, where they're looking at sort of a levels of care, more of a population-based view of ensuring that there's options across all of the levels of maternal care for any given population. So those were some of my thoughts of how to strengthen it.
Thank you. I mean, we heard some good and important testimony earlier today about some of the things that should be done with 986 voices to be added. Those, I don't think we had heard those two before, so that was helpful input. Thank you, Mr. Chair.
Thank you. From Representative McCarthy-Vahey to Representative McCarthy.
Thank you, Mr. Chair. And just very quickly, thank you for your testimony and for your words saying that you set up a model birthing center during the pandemic. Thank you for that work. I think I heard you say that you went from 7 weeks, what normally may have taken much longer, 7 years, I think you did say. Can you tell me when you set that up in that short of time with, I would imagine there was not as much regulatory oversight. Can you just speak to that a bit about, so as we go forward looking at this, did you feel that there were any measures that were lost in that duration of time that you set that up?
I think it was really, such a unique moment where everybody was swimming in the same direction, and it was clear to everyone that having the only option for people to give birth to be a hospital when the hospitals were just completely overrun and had transformed into infection zones overnight was just an untenable situation. So there was just, it's what we're seeing here is, there was momentum, there was a governor who cared and had a commission, already in place that was trying to move forward birth center regulations even before the pandemic. And so there was that sort of coming down from above that this is important, let's make it happen. The major changes that happened that enabled the project to move as fast as it did was temporary removal of the certificate of need requirement, which is one of the strictest in the country. New York has only 6 birth centers. Other states like Florida and Texas that have a similar number of births but don't have the certificate of need, and that's the major difference, have dozens of birth centers. So it's the major factor. But New York got rid of that. And there was one existing birth license holder in the city of New York, and that change allowed that site to add a location. So it was a really unique opportunity. The other regulatory opportunity we were able to take advantage of was bringing in nurses and midwives from other states to work on their out-of-state license while they were in process to get licensure in New York. Because when you have a location that has so few birth centers and a pandemic brewing where everybody's out and, there was no capacity within New York to hire a bunch of midwives who were familiar and competent in the birth center model of care to you could train people obviously, but the time was of the essence. So the ability to take experienced birth center midwives from around the country who were sort of ready to step up was a big part of how we got it open so quickly. But I really don't feel like we skipped steps. I can add to my written testimony a YouTube link with a little brief vignette of how it all came together. But we were doing emergency drills, activating, the transfer pathways with the hospital partner. They were at the table designing, how transfers were going to go with us, even though, again, they were responding to the pandemic in real time. So, but it really was that everybody said, look, we need access to something for people, and let's all make it happen. The question we should be asking is, why does it take 7 years? Why can't you just open up a birth center in 7 weeks? It's not a complicated care model. There's a million tools. I've developed a lot of them to help people, have the appropriate eligibility criteria and policies and procedures and infection control. All of that stuff is not rocket science. What takes forever and costs so much is navigating these.
Romano, can you keep your answers somewhat short if you could?
Sure. I'll wrap it up. But it's really the
past our 5 minutes
regulations,
or-
regulatory environment, and some of the payment challenges as well that make it take so long when we have proof it can happen quickly when we're all moving in the same direction.
And we do have other people who want to ask questions. That's why I wanted to just keep things moving. We have Senator Kushner who has a question, followed by Representative Kennedy.
Thank you. Thank you, Amy, for testifying today. I have, as you know, Danbury has the only birth center in the state of Connecticut, and it's currently licensed under the maternity hospital licensing. And I became aware of this 4 years ago when I got elected, and that was when the effort began to, and I think you had been working on it before that, by the way, but to really have the proper licensing of a birth center. And so I really appreciate your work on this, as well as I know we're going to hear from Kathy Parisi later. But I think a few questions that, a few things have come up throughout the day that I would like you to address, because they were questions I had too. I mean, the first one is really, the question about distance from a hospital. I think the issue being that people are concerned about the possibility of an emergency and the need to transfer to a hospital. And I wonder if you could address that in some comments.
Yeah, I think, no matter what the distance, all birth centers need to be prepared for emergencies. And it's a big part of the accreditation requirements is to demonstrate preparedness. And so that usually is done with drills and in-service trainings that are required for everyone to participate in, and that optimally engage, the EMS and hospital systems and so on. So it's really part and parcel with the model of care that there are, plans in place, written plans and plans that have been practiced for all, the various kinds of emergencies that can happen. That said, the vast majority of transfers are not urgent. They happen for things like require, desire for pain management or a slow labor progress that needs, medicine or other interventions to speed it up. And midwives are the model of care is very preventative. So it starts with really like continuously screening out the people who are likely to develop complications. And so it's a really continuous screening process combined with a really judicious kind of approach where you don't wait, you don't go all the way out the limb until you decide it's time to go to the hospital. You're looking at kind of the constellation of factors and what your resources are here versus, if we were to change locations and be at the hospitals. So what I would say about distance is that the only thing we know for sure about putting a distance requirement is that we're not going to have any birth centers outside of that distance. And we're dealing with a maternity desert forming. And so if we want to think outside the box of how we might be able to situate a facility that has 24/7 access of at least a basic level of care and can take care of the truly low risk women in that population, but also can be a place where you can come get your blood pressure checked or take your childbirth classes or have your prenatal care, but still deliver at the hospital. So birth center is not just a place to give birth, and to restrict where we can put it means we're saying this is not a solution to the maternity desert problem. And it's not ideal to be 45 minutes from a hospital and be doing birth center birth, but it is something you see in other countries. You see it, there's Alaska has a huge number of birth centers because they have lots of places that are just not served and you need some level of care there. So there's a role for these rural birth centers. They typically self-correct for what kinds of risk they want to take on to be able to do in the center versus refer out. And all centers, regardless of distance, have to be prepared and really know the step-by-step what happens. And that's why the hospital partnerships are so important. You could be 2 blocks from a hospital, but if they're going to not be collaborative or not have a clear process for how you actually move a patient, and do you go through the ER or do you go straight up to the floor? I mean, just doing some basic planning about how transfers should go can really shave the time, so that if you have a problem and the hospital can be activating and ready, you can just roll right in and have the C-section or do whatever the emergency thing is.
Romano, thank you so much. I want to keep the limit to 5 minutes for the entire conversation. I think Senator Kushner, you're done, I believe, right?
I was not done, but I will make sure that the committee has an opportunity to hear more from these witnesses, because in fact, these are the folks who are doing this work in our state, who are already involved in the birth center in Danbury, which I know people have had wonderful experience with. So I think they're very important voices, but I will respect the chair and not ask any further questions.
Thank you. So sorry to interrupt. I do have Representative Kennedy who has a question too.
Thank you, Amy, for your testimony. And just very quickly, you said you were located in Milford. Can you tell me where in Milford you're located?
I live in the Wildermere Beach area.
No, where your facility is located.
So we're a consulting firm. So I have
Oh,
a
it's a
team
consulting
that
firm.
is, so
Okay.
I work out of my house. Yeah, but we
All
have
right, that's
a
fine.
team that works on a number of activities and
Thank you very much. I appreciate it. Thank you, Mr. Chairman.
Thank you. Seeing no other questions or comments, we'll move on to the next person on our list, which is Stacy Hardy Chandler. Welcome. Thank you for your patience with us today.
Thank you very much. Chair, distinguished members of the Public Health Committee, thank you for the opportunity to address you again. My name is Stacy Hardy Chandler, and I'm the CEO of the Association of Social Work Boards. As a brief reminder from my testimony on March 6th, ASWB develops and administers the social work licensure examination as part of the support and services to regulatory entities in all 50 states and 4 U.S. territories. On behalf of the only nonprofit organization dedicated to social work regulation, I'm here to oppose House Bill 6733. Our opposition is specific to the bill's provision of issuing a license without an examination and is based on, first, the extensive objectivity and anti-bias measures that go into the development of professional licensure exams that make them a distinct element of the licensure equation. And second, the fair and objective competency measurement being a vital part of licensure decisions. And finally, the public's need for consistency regarding what it means when services are provided by an individual using the title licensed social work. We also want to acknowledge many other ways to attract, and what hasn't been mentioned yet, retain social workers to serve Connecticut. This month is not only Women's History Month, as was mentioned earlier, it's also Social Work Month. And this year's theme is breaking barriers. Last year, ASWB broke a major barrier by becoming the first health or human service regulatory association to analyze and publish pass rate data disaggregated by race, age, gender, demographics. This was a groundbreaking decision, but it was done as an act of licensure justice. Disparate outcomes revealed by that, like most fields evolving from historical and institutional marginalization in the US, social work was not immune from those systemic impacts. The tool is not the cause. Social work candidates are, before they become candidates, members of our society and subject to the various systemic and institutional factors that have been discussed in a prior testimony related to other health factors. And the exams serve as an important metric for holding the profession accountable. So licensing insurance issuance decisions include education, experience, and an examination. And as with licensure examinations for all other health professions like medicine, like nursing, like pharmacy, psychology, social work examinations are reliable and valid and involve a psychometric process that adheres to industry standards developed jointly with the American Education Research Association and others. Employing a state-of-the-art competency measurement process involves both subject matter experts and strong third-party psychometrics. It begins with a practice analysis, which forms the blueprint. The practice analysis simply asks practicing social workers what entry to practice knowledge should be demonstrated by those newly starting out in the field. The next practice analysis will take place in 2024. So the next blueprint is coming. Exam writers are also practicing social workers. They're recruited from all segments of the profession, and they're recruited to reflect a microcosm of the field in terms of our state.
Excuse me, Dr. Chandler Harding, your time is up. Thank you.
I welcome questions.
Thank you so much for your testimony. Representative McCarthy Way has a question or comment.
Thank you.
Thank you so much for hanging in here with us all day. And as you know, this committee has now twice had this conversation about how we move forward. And you have been raising some very important points. And I just want to go back to what you said, being the first body to actually analyze the tool, right?
Yes, ma'am.
And so I think that's an important point. In part, I think the other thing you said the tool is not the cause.
Yes.
So as I think a lot of us here, well, I shouldn't speak for my colleagues, but my sense is that people feel somewhat persuaded by the argument that this is what we're seeing. And I hear the case that you're making, which is, you know, we really shouldn't just look at the tool as the cause, and we should be able to examine additional data. So I just wanted to, it's more a comment than anything else. I think the idea of a pause as opposed to an elimination is probably what makes more sense.
Well, I appreciate your comment very much. And we actually did a webinar on all of the psychometrics that go behind the test, including presentations by our educational partners, really emphasizing that this test is picking up some of the things that are part and parcel of our society across the board. And we know that people are not coming to the exam process equally prepared with equal opportunities for preparation. We know that they have different experiences in their education in terms of competing needs, taking care of families, all kinds of things that have come up in prior discussions apply to social work too. So the years leading up to the examination are important, which is why we want to work collaboratively across the profession. While we're continuously, the argument to pause the exam to analyze it, I just want to emphasize that professional licensing exams are continuously analyzed. And as I mentioned, the next practice analysis is coming up just next year. But in the meantime, all of the psychometric measures of the individual items, that is an ongoing process. And all of those issues are in terms of the anti-bias measures, those are identified before any item gets onto the scored part of the test. But happy to provide presentations on how that test development happens, because I think people think of their college exams, and this is very, very different. So thank you for your comment.
Thank you, and thank you for that additional information as well, and for your testimony. Thank you, Mr. Chair.
Thank you, Madam Co-Chair. Seeing no other questions or comments, we will move on to the next person on our list, which is Rebecca Torrens-Barker. Ms. Torrens-Barker, you're on. Thank you for your patience and welcome.
No problem. Thank you so much for having me. Greetings, Chairman Anwar, Chairwoman McCarthy-Vahey, Ranking Members Summers and Clarides-Ditria, and distinguished members of the Public Health Committee. Thank you for your long day. My name is Rebecca Torrens-Barker. I am a licensed massage therapist, and I am a chairperson of the American Massage Therapy Association Connecticut chapter. I wish to offer the following comments in support of Section 2 of HB 6835, an act concerning various revisions to the public health statutes as it relates to continuing education requirements for licensed massage therapists. Section 2 of the bill increases the number of units of continuing education that massage therapists can earn via the internet or distance learning. Currently, LMTs can only earn 6 continuing ed units virtually. This bill seeks to modernize the statute and allow for up to 18 hours to be earned in that manner. Even post-COVID in 2022, in-person education was still largely unavailable in our industry, resulting in massage therapists having to incur additional travel expenses and other expenses related. Since 2020, at least 3 states have changed their statutes to allow for more virtual education. During the first COVID year, at least 24 of our members started reaching out requesting a change in our statutes. In 2022, we surveyed our Connecticut membership, and members are in support of this change. In addition, AMTA's National Government Relations Department which tracks massage legislation nationwide. They also support this change, and they've submitted written testimony as well. In addition, the Massage Therapy Continuing Accreditation Agency, which is the National Certification Board for Therapeutic Massage and Bodywork, they approved this change as well. Lastly, many of these virtual classes are actually hybrid in format, with hands-on learning still occurring in person, and the didactic portion is online and frequently requires a webcam to be turned on. So all of this means that classes are not simply watch a video and take a quiz type learning. The increase will also more closely align massage therapy continuing education requirements with that of other healthcare practitioners in our state. And by allowing virtual education to count towards licensing renewal, massage therapists, as I mentioned, save that extraneous travel cost, and they can apply more of their continuing education budget to actual education. We also wish to thank the Public Health Department for including this increase in their bill. Thank you so much for your time, your consideration, and support.
Thank you so much for your testimony. And seeing no questions or comments, we are going to move to the next person on our list, which is Samantha Liu. Ms. Liu, you're on. Welcome.
Thank you so much. Good evening, Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the Public Health Committee. Thank you so much for accepting this testimony in support of SB 986 on behalf of Health Equity Solutions, a nonprofit organization with a statewide focus on advancing health equity through anti-racist policies and practices. HES strongly supports this proposal, and we also commend the efforts of DPH and the Doula Advisory Committee, which are reflected in this bill. This proposal establishes a formal voluntary state certification process for doulas, whose work is vital to the health of birthing persons across the state, and commends the efforts of this proposal, as I mentioned. Doulas and the care they provide can improve outcomes and help address the health inequities pervasive today. Racial inequities and pregnancy-related deaths persist across all income and education levels for Black women in the United States. These inequities are rooted in structural racism, and the majority of birth-related deaths are preventable. Evidence strongly suggests that providing doula support through Medicaid reimbursement is likely to reduce these significant racial health disparities. Connecticut has also begun a reimbursement effort through the Medicaid maternity bundle, but doulas have expressed concerns about being paid by physicians and note that certification could make direct reimbursement possible. Establishing a voluntary certification process will help increase the visibility and recognition of the doula profession, establishing more sustainable funding options for doulas, expanding the use of doulas across the state, improving integration of doulas into the health system as a non-clinical member of the care team, and that is a clear standard for who is and who is not a doula. This will in turn make it far more likely and simpler for public as well as private payers to cover doula services, and for medical practices and hospitals to collaborate with doulas. We also offer recommendations, which I have outlined in our written testimony, 3 key areas. Updating so it reflects a state certified doula, allowing out-of-state certified doulas to apply to Connecticut no less than 2 years of certification. And then lastly, updating the experience pathway to supporting 3 families and completing training in at least 3 core competencies. We do also support other key areas in this bill today, efforts to establish birth centers, universal home visiting that includes community health workers, and the creation of an infant mortality review committee, which we do recommend adding a doula, as a few have mentioned today. Thank you so much for the opportunity to testify in support of SB 986, and I'm happy to take any questions.
Thank you so much for your testimony. And seeing no questions or comments, we really want to thank you for being here today and your very important testimony. Next person on our list is Catherine Parisi. Welcome. Thank you for your patience. Please go ahead.
Good evening, honorable chairs and all members of the Public Health Committee. My name is Catherine Parisi. I have been a certified nurse midwife since 1994 and have been part of the Connecticut Childbirth and Women's Center in Danbury, Connecticut as the only accredited out-of-hospital birthing facility since its inception in 1997. And for the last 25 years, I've been the clinical administrative director of the center. I am here to testify today in support of Senate Bill 986, an act protecting maternal health care. The bill is a good start to increasing access to maternity services and care which have been shown to have consistent positive maternal and neonatal outcomes. These outcomes include fewer preterm births, lower maternal and neonatal morbidity and mortality, and improved patient satisfaction, just to name a few. Women come to Danbury from all over our state and nearby New York, Massachusetts, and Rhode Island. Many families traveling 1 to 2 hours each way to receive the care in our office with the intent of birthing in our facility. Increasing access to birth centers across Connecticut by opening the doors to regulation and accreditation will not only help fill a birthing void caused by the recent closures of birthing facilities, it will also make access to centers geographically closer to these women that are away from us, make it more available and thereby more convenient and safer for these families. However, the bill needs to go further and address access to midwifery services inside our state's hospitals as well. There are women who either risk out of delivering at our birth center or not candidates for birth center care, or simply desire services offered inside of a hospital, such as epidural anesthesia or a prolonged postpartum stay, which are not available in a birthing center, and they want these with a nurse midwife. Unfortunately, while many of our state's hospitals allow midwives on staff, they often only allow them to practice in a limited ancillary capacity, and this limitation must change. Connecticut certified nurse midwives are licensed by the Department of Public Health as independent practitioners, and as such, we have been granted licensure to function autonomously within our profession. And yet in many hospital institutions, we are denied the right to admit our own patients under our own names and with our own credentials. There are a couple of hospitals in Connecticut that do grant midwives admitting privileges. However, many more do not, and in fact, make functioning within their walls a constant bureaucratic game of what a nurse midwife is allowed or not allowed to do. Today, there are even hospitals in Connecticut with active maternity services that continue to refuse to allow a licensed midwife to even apply for privileges, let alone maintain them. Because of hospital administrative bureaucracy, the midwives in my own practice in Danbury have temporarily stopped attending births at Danbury Hospital. In July of 2022, the hospital administration demanded that we sign a collaboration agreement that would effectively make the staff attending obstetricians our direct supervisors, responsible for any and all care that we provide. This is tantamount to anti-competitive behavior. And sadly, as a result, after 25 years, we may never care for hospital patients again. It would only seem sensible to expand Senate Bill 986 by mandating that all hospitals with maternity services allow licensed midwives to have admitting privileges to function within their scope of practice. Hospitals with maternity units that grant privileges to obstetricians should also be required to grant privileges to licensed midwives. And only by allowing and encouraging licensed midwives to practice in the scope of their licensure and profession, both in and out of the hospital, can we continue to
Yes. Excuse me, Ms. Parisi, your time is up. Thank you.
Thank you.
Ms. Parisi, if you want to just complete what you were just finishing.
Thank you. I'm almost done. And only by allowing and encouraging licensed midwives to practice within the scope of their profession, both in and out of the hospital, can we continue to improve access and care for all women in Connecticut, leading to proven better outcomes for mothers and babies, which is, in my opinion, the intent of SB 986. It's a great beginning, and I applaud Governor Lamont and the members of this committee. And we would like to act together to provide access to maternal care for all women in and out of a hospital setting. Thank you very much for your attention.
Thank you so much. We have a few comments and questions. I will start with Senator Kushner. Senator Kushner, you're on.
Thank you, Mr. Chair. And I want to thank you, Kathy, for being here tonight. I have toured this center on a few occasions, and I know it's a beautiful facility, and that you do exceptional work there. So first, I want to just thank you for doing that. I want to clarify a couple of things. I know that earlier we heard testimony about accreditation that you currently have. And I don't think people are as familiar with the association. So I wonder if you could just briefly describe CABC.
Yes, the CABC is the Commission for the Accreditation of Birthing Centers. It's a national accrediting agency, which provides very strict licensure and accreditation criteria for safety in birth centers. There is an initial accreditation, and then every 3 years, maintaining that accreditation means that we have a site visit. We're actually coming up for one in a couple of weeks, where we must maintain safety standards. We must prove that we have stayed safe and that we are keeping with current recommendations for providing mothers and their babies and families with care that is at or above regulations for the country.
And the birth center in Danbury, how long have you had that accreditation?
We've had it since our inception in 1997.
Right. So I know in one of our discussions that one of the things that we talked about with the governor's bill, and I know you supported it, I think it's fabulous, but there are some things that might be improved upon. One thing would be to make sure that the inspections are done by CABC, because they know this inside and out, as opposed to developing a new structure within DPH. Can you talk a little bit about that?
Yeah, sure. The people who come and do the site visits, the CABC themselves, are aware of what it takes to keep a birthing center safe, satisfying, and provide care that is appropriate for being in an out-of-hospital setting, such as things like not using vacuum or forceps, not using things that are appropriate in an out-of-hospital setting for a higher risk woman, but not necessarily in a birthing center. We don't perform twin deliveries. We don't do breech deliveries. And these are national standards to maintain safety within the birthing center. And so, in my opinion, for the state of Connecticut, in SB 986, requiring accreditation by the CABC would be a very good step to maintaining safety in birthing centers.
Thank you. And another issue that I know we've discussed is about who determines that a person coming to give birth is low risk.
Yeah, that's actually a really good question. It's both by policy and procedures. We do have risk criteria for what women may participate in delivery in the birth center. And those criteria are made up from national standards by the CABC. And so the things I talked about, preterm delivery, post-date delivery, babies that are excessively large or excessively small, twins, breeches, those are things in an accredited birthing center that you would not expect to find.
And there were some questions about the number of patients or persons giving birth that are transferred. And I think it was 1 out of 5. And what's been your experience in Danbury here?
We actually participate in a national patient data registry with most birthing centers in the United States, and we keep our own statistics as well. And since 1997, when we opened, our average transfer rate for women who are admitted to the birthing center in labor is about 10%. The national average for all birthing centers in the United States is about 14 to 15%. So we've maintained a lower level of transfer with as good or better outcomes than national standards as well. So it's not like we're keeping people and then ending up with an issue. And it's important to provide those statistics and to think about what we're keeping there and who we're not having in the birthing center.
And I know I was asking you about the fact of distance from the hospital, because in Danbury you're right across the street from the hospital, so that wasn't a question that I had. But I know we talked about the fact that having a birthing center in an area where there is no hospital could actually be a plus for people who might have an emergency and not have anyone nearby to go to for help. And I wonder if you could explain that a little.
Sure. If you have a birthing center that is close to a hospital, such as we are, that definitely appeals to a certain portion of the population. And then we do have women who will be somewhat reticent, them or their families, about delivering until they see that we are directly across the street. But to speak to what you're asking about, if you have a birthing center that's 30 or 40 minutes from a hospital setting, because that's just where there's a location need, we would probably, as a facility, as Amy Romano was talking about, be more cognizant of things that would require a transfer, or maybe not have somebody deliver there. What we do find is that women who are coming from very far away, even to Danbury, it'd be better for them to have a birthing center that was closer, so that there was not that issue of perhaps a second time mom getting in her car and driving to drive an hour to Danbury and delivering, halfway there, which is obviously not a very comfortable or safe situation.
Thank you. And I know that there are some details in this. You scoured it very closely, the bill. So I would encourage you, any comments that you might have that you think would strengthen the bill, please include those in your testimony or get them to us. But I just, I really appreciate you being here tonight. And I know there are hundreds of women who appreciate the work you've been doing in our community for a long time, because I hear from them when there have been some concerns about your continuation and your relationship with the hospital. Hundreds of women contact me. Thank you.
Thank you.
Chair.
Thank you. Representative Wieslander.
Thank you, Mr. Chair. Full disclosure, I just wanted to say hi to Kathy. Kathy, I think one of the last times I saw you, you were helping deliver my third baby, who's now almost 11 and a half years old. So
you're making me feel old.
Me too. I probably more of a comment than a question. Just wanted to, again, lend my support behind this provision. Having had an incredibly successful and supported birth at the birthing center, and also with my older daughter, a successful birth in a hospital setting with midwives. I think your suggestion to expand the midwifery presence is an excellent one, and I would fully support that. I think all of these actions only lead to improved outcomes for people who are giving birth and for their children. So that's mainly the gist of it. I wanted just to say thank you for what you did for me and my family, and what I know you've done for hundreds, if not thousands, of women and families across the state. And thank you for being here tonight and sharing your expertise with us.
Thank you.
Thank you, Representative Wieslander. And my co-chair has a question or comment. Representative McCarthy.
Thank you so much, Ms. Parisi. And I found it moving to just listen to Rep. Wieslander talking with you. And I confess to Senator Anwar that earlier, as you were testifying, my mind was wandering to my own childbirth experiences. These are such formative and transformational moments in people's lives. I lived on the West Coast when my oldest was born. So as is often the case, the West Coast is a little ahead of us on the East Coast with some things like this. And I had a close friend. She was kind of my mom mentor. She was 6 months ahead of me giving birth, and she tried to have a home birth, and things went awry. She ended up needing to go to the hospital. When the time came, I ended up going to a nurse midwife in a hospital setting. This leads to my question, which is, you talked about the fact that the relationship with Danbury Hospital has changed at this point. So for example, if someone like my friend, though not at home, but at the birthing center, would then need to transition to the hospital, it would make sense to me from a continuity of care standpoint that the certified nurse midwife would then follow. And I think your comment about the change in relationship to Danbury Hospital is concerning, and some of your comments in terms of what needs to happen for certified nurse midwives to be able to practice and provide that continuity of care in the event of needing to transition. And so I'd like for you to comment on that. And then also, if you could, tell us how often you find that you have people needing to go from the birthing center to the hospital, because I heard what you said, you try and prevent that from happening through the assessment process ahead of time.
Yeah, so currently we do have a relationship with the physicians on labor and delivery. That relationship hasn't really changed. What has changed is that where we used to transfer with our patients to the hospital and continue to provide them with midwifery care, and in most instances still deliver those babies in Danbury Hospital's labor and delivery unit. Maybe it was somebody who wanted an epidural, which is probably the most common reason for transferring. Maybe she needed some Pitocin, whatever. We would still stay with those women and deliver them. Because of this requirement for a collaboration agreement that the administration is imposing upon us, we are unwilling and unable, and quite frankly, the physicians who are have been covering us for all these years are also unwilling to sign this collaboration agreement. So we're kind of stuck in a mire of what do we do from here. So for now, we are very transparent with our patients. When they come in for their first visit, they are well aware from the very first visit that we have not been doing delivery at Danbury Hospital since July, and that if for any reason they needed to be delivered in Danbury Hospital, seen in Danbury Hospital, the attending physicians who have historically provided us with backup for birth care are willing to take these patients in. It's not an ideal situation. Our patients are not happy with the situation, despite the care that they are receiving, which is good care. They want their midwife, and unfortunately, we've been unable to provide that. As a side note, I thought after we were out of the hospital since July, we would lose way more patients than we did, because we do have a very robust hospital practice where women are coming to us who really want midwifery care. They like the attention that we pay and all the things that midwifery care provides, but they don't want to be in a birthing center. And maybe it's not because they risk out. Maybe it's because their girlfriend comes here and she really likes how we see them on time and the care we provide. So they're delivering in the hospital anyway. And we still have a couple of hundred women a year who are coming to us and continuing to see us for their prenatal care, but then planning a hospital delivery. And then they come back to us for their postpartum care. That's also not ideal. All 4 of my grandchildren were delivered in Danbury Hospital. And I would be amiss to say that I would have been okay missing helping with the births. I miss doing deliveries at Danbury. So do my other midwives. We miss providing that care, but unfortunately, we do have a system with the hospital. It's just not perfect. And as for transfers, we transfer 10% of our women who are admitted in labor. The vast majority, I would say 95%, are for non-urgent reasons. And it's usually the first-time mom who wants an epidural, or it's a first-time mom who's been pushing for 2 hours and the baby's just not coming. It's very rarely for an emergent reason. I don't know if I answered that question thoroughly for you.
No, you did. So I guess the one follow-up, if I may, Mr. Chair, which is that what you're talking about, I guess I'm wondering about the bill and the need for a collaborative agreement. Is that going to then result in this situation that you're facing happening across the state? In other words, I think this is an important question to ponder, because as a provider, you know this, and I know it as a mom having birthed 3 children, there's a special relationship that you have with that provider. And obviously life sometimes gets in the way, but you want the person who's taken this journey, this maternal journey with you, to be able to be there when the day comes to deliver. So is it your sense that this bill would cause a similar issue?
No, we actually have a collaborative agreement with Danbury Hospital and have since its inception. I'm not sure. I know looking at the bill, it appeared to me that it would be a requirement that a hospital would be open to accepting women who were coming from a birthing center. Somebody at one of the meetings we've had was talking about, what if a woman is from out of town? She shows up from San Diego and she's 36 weeks pregnant and her water breaks. She's not going to get on a plane and go back to San Diego. She's going to go to the local hospital and she's going to be cared for, because that's what facilities do. I'm not 100% sure we need to have collaborative agreements in writing, but I do think that there needs to be an understanding that if there is a need to transfer someone across the street, they'll be accepted there.
Thank you so much. Thank you, Mr. Chair.
Thank you.
Thank you for your testimony. This is very helpful. Thank you for the work that you do. And with that, we'll move on to the next person on our list, which is Gregory Allard. Mr. Allard, you're on.
Good evening. Thank you for having me. Senator Anwar, Representative McCarthy-Vahey, and other distinguished members of the Public Health Committee. My name is Greg Allard, and I'm the president of the Association of Connecticut Ambulance Providers and the vice president of American Ambulance from Norwich, Connecticut. I'm here today to testify in opposition of two sections, Section 7 and Section 25 of House Bill 6733, the act concerning the Department of Public Health's recommendations regarding various revisions to the public health statutes. Both are related to EMS. And Section 7 in particular has to do with co-branding of ambulances. And really, there is no public safety or public health reason for this proposal, in my opinion. And the change would result in an unfunded mandate to alter existing fleets and would eliminate the opportunity to show a community what organization proudly supports the ambulance service. For example, several ambulance services are co-branded with a hospital name or with a local other service that might be supporting the ambulance service. And it's been done this way since as long as I've been in EMS, and it continues. And so I'm not really sure what the need for the change is. And so therefore we oppose it. The opposition to Section 25 is a little more detail needed to explain that. By way of background, the Department of Public Health provides licensure for certification to EMS organizations across the state. So it's licensure and certification. Certified organizations are able to provide emergency responses only, while licensed organizations provide both non-emergency and emergency transportation. So this ensures enough ambulances are ready to respond to emergencies is a critical reason for limiting certified organizations to emergency responses. So again, certified services or certified organizations only handle emergency, licensed handle both. The proposal that they're putting up in this section is suggesting that the commissioner be able to put in rates for certified ambulance services to go ahead and do non-emergency transports. There is currently a process in place that an EMS organization can follow to obtain rates to become a transport service to do non-emergency work. The process requires an application to go into the Office of Emergency Medical Services to undergo a hearing to become a licensed service. If the process is successful, they'll allow that organization to then have rates established and allow them to conduct those non-emergency transports. The commissioner also has the ability to temporarily allow for certified EMS organizations to conduct non-emergency transports, such as the recent public health emergency or related to COVID-19, and then for such incidents as a large-scale incident like a facility evacuation or a mass casualty incident, those types of situations. A service from Killingly, Connecticut just went through that process. They actually put in their application. A hearing happened, and then they're now currently waiting to their decision. So that clearly exemplifies that the process is there and it could work. And for those reasons, our association believes that any variation from this process would lead to system issues and failures. And by that, I mean that if a number of these certified services are out and available to do non-emergency transportation, they could be out doing non-emergency transportation, and with their limited resources in those smaller services, they wouldn't be available for emergencies, which would then put onus on other organizations.
Excuse me, Mr. Allard, but your time is up. Thank you.
Great. I was just finishing. saying I welcome to answer any questions or have further discussions for the committee at any point.
Thank you so much, Mr. Allard. Appreciate you staying the day with us and then listening in and sharing your important comments. I think they are very valuable. We will make sure that is looked at, and we'll consider that for sure, because that's very valuable to us. Seeing Representative Wiehlander has a question or comment. Representative Wiehlander.
Hi, thank you, Mr. Chair. I was wondering, Mr. Allard, could you repeat the section that you were referring to again, please?
So there's two sections that we were opposing, section 7 and section 25.
Thank you.
You're
I
welcome.
appreciate that.
No problem. I did supply written testimony as well.
Yes,
Oh,
we
perfect.
appreciate
I will
your
go back
written
and look.
testimony. Thank you.
Thank you,
You're
Mr.
welcome.
Chair.
Thank you. Seeing no other questions or comments, we'll move on to the next person on our list, which is Dr. Mark Becker. Dr. Becker, you're on.
Hi, good evening. Honorable Chairman, ranking members, and distinguished members of the Public Health Committee. My name is Dr. Mark Becker, and I serve as the Senior Director of Global Medical Affairs for the Grifols Plasma Procurement Business Unit. Thank you for the opportunity to testify in support of Section 8 of House Bill 6733 with modification. Grifols is a global healthcare company that develops medicines derived from plasma. Grifols operates the largest network of plasma donor centers in the US, with 300 centers, including centers in Massachusetts, Maine, and Rhode Island. We proudly serve approximately 40,000 donors across our network of plasma donor centers each day. These FDA licensed centers are highly regulated, and all aspects of the plasma collection process are controlled by strict standard operating procedures, which are approved and regularly reviewed by FDA. Plasma donation is a low-risk automated procedure, and most donors experience minimal or no adverse effects. Grifols does not currently operate any plasma donor centers in Connecticut due to the regulations that are not aligned with federal regulations and require center staff qualifications that are challenging to comply with, given the current and likely future shortage of physicians in the US. We thank the Connecticut Department of Health for their work on addressing this issue. We support the Department of Public Health establishing regulations that will govern source plasma donor centers. We encourage the department to implement policies and procedures that mirror federal law. We also thank the department for working with us over the last 3 years to understand the need for updated regulations, including last year's House Bill 5500 that would allow the department to waive any provisions of the regulations of a clinical laboratory. Based on the passage of House Bill 5500, Grifols has been preparing to open and operate a donor center in Stamford, which is estimated to contribute over $5 million to the Connecticut economy and employ up to 50 local residents. However, the department has not granted any waivers, and therefore we're asking for an expedited timeline by changing the effective date of the bill from October 1st, 2023 to July 1st, 2023, so that we can open and operate our center as soon as possible. We want to be part of the communities in Connecticut, and we're committed to the health and safety of donors and ultimately the health of the patients who rely on our medications. Thank you for your consideration of this legislation.
Thank you so much for your testimony. We appreciate your insight, and I'm not seeing any questions or comments from my colleagues. So thank you so much for your testimony.
Thank you for your time.
Thank you. The next person we have on our list is Ms. Vanessa Henneman. Ms. Henneman, you're on. Welcome.
All right, thank you. Thank you for your patience today with the really important issues today. Chairs Anwar and McCarthy-Vahey, members of the committee, my name is Vanessa Hanneman. I'm here representing the Association of Surgical Technologists. AST is a national organization that represents more than 50,000 surgical technologists whose primary purpose is to ensure that surgical technologists have the knowledge and skills to deliver high-quality patient care. My testimony is supplementing written testimony submitted by Jonathan Brown, the president of the Connecticut chapter of the Association of Surgical Technologists. He works at St. Vincent's Medical Center in Bridgeport. AST thanks you for the opportunity to testify in favor of Section 1 of House Bill 6835, which sets minimum education and certification standards for surgical technologists. And we appreciate the inclusion of this language in House Bill 6835. AST was officially incorporated as a nonprofit to ensure that surgical technologists are educationally prepared to deliver high quality patient care.
Miss Hanneman, I think your signal is restricting us. We'll wait for about a few seconds and perhaps we can all stretch our legs for a second while we wait for the signal to connect. Well, we can come back to Ms. Hanneman in a second. What we can do is we can go on to the next person on our list, Mr. Paul Kidwell. Mr. Kidwell, you're on. Welcome.
Good afternoon or good evening. I'm Paul Kidwell with the Connecticut Hospital Association, and thank you for your indulgence as it seems like there's a parade of CHA staff through the committee today, but there are a number of issues of relevance and importance, and so we appreciate your attentiveness to these issues. I'm going to confine my comments to the 340B provisions in HB 6669, and I think you've heard from my colleagues Jim Acabelis and Carl Schissel related to some of the other provisions today. As you heard earlier today from colleagues at the federally qualified health centers, the assistance made possible by the 340B program is felt by communities across the state. 340B was established approximately 30 years ago to allow certain hospitals and other covered entities like FQHCs to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. Access to drug discounts provided through the program assists hospitals in meeting the needs of their patients in vulnerable communities. The savings derived from the program, meaning the difference between the discounted price at which covered entities are able to purchase 340B drugs rather than the non-discounted price they would otherwise be required to pay, supports the nearly $1 billion in unreimbursed care for low-income Medicaid beneficiaries in our state provided each year, the nearly $250 million in uncompensated care provided each year, and the millions in community investments provided by hospitals across the state. As such, we support the sections 16 and 17 of the bill, which seek to rein in practices imposed by pharmaceutical manufacturers and PBMs that limit the success of the program. We do, however, oppose section 19 of the legislation, which seeks costly and impractical reporting to the state government by covered entities. The reporting in our view is unnecessary and unworkable. For example, a provision of the reporting misunderstands how certain services are provided in the outpatient setting and reimbursed. In many instances, outpatient services include and are billed with the drug costs as part of the overall service, not separately. Segregating the payment for the drug component of the overall outpatient payment is out of step with how these services are packaged and paid for. As I noted, the purpose of the program is for covered entities to use program broadly to reach more eligible patients and offer more comprehensive services. Hospitals are able to support our financial service assistance policies, which provide free and reduced care in part due to 340B program savings. Hospitals strive to ensure the inability to pay for services does not deter anyone from seeking needed medical care, and 340B participation helps support the ability of these hospitals to offer financial assistance beyond statutory requirements, helping to ensure more patients are able to afford their medical care. Unfortunately, the section of the legislation adds a necessary burden to 340B covered entities with no benefit to patients, and we respectfully ask that section be removed from the bill. Again, I appreciate the longevity of the committee this evening, and I'm happy to answer any questions. Thank you.
Thank you so much, Mr. Kidwell. We're actually getting warmed up here. So I wanted to ask you a question, because the bill is not taking any money away from the healthcare systems. It's just asking to find out what the dollar amount is. And even then you have a concern with that.
Yeah, so I think we certainly our main concern is the actual ability to comply with the reporting requirements. So as I noted, the 340B program is not a patient-specific discount. The savings derived from the program are then to be used, as the federal requirement notes, to extend those hospital services to a larger population of individuals. So in the way the outpatient drug could be administered is within a package service. So the ability to comply with the reporting from our perspective would be difficult, if not impossible. We do think, however, there is value in reporting the types of benefits that 340B provides, and we already do that. We provide, as not-for-profit organizations, our community benefit spending to the state and the federal government on an annual basis. And as I noted, that is where the 340B savings, by and large, is provided.
So in our conversation, thank you for your answer. In our conversation with the commissioner earlier this morning, they were probably the number 2 people on our list this morning, about almost 9.5 hours ago. But their issue was that they felt that there's a need for transparency for the healthcare systems. And that's the purpose of this part as one step. And once we look at the transparency and look at the total benefits that the healthcare systems are getting, it just gives an insight into areas of opportunity and better understanding.
So a survey, I think approximately 2 years ago, of 340B hospitals noted that the approximate savings to a dish hospital, so those hospitals that are eligible for the program because they serve a disproportionate share of low-income individuals, the median savings was approximately $9 million a year. Again, we report community benefit spending on an annual basis. We report Medicaid underpayment on an annual basis. That reporting is available and valuable. We think there's a lot of transparency related to how these savings go into supporting financial assistance policies, Medicaid underpayment, and other community benefit spending already.
So your testimony is that you're already doing it, so why put it in a legislation?
We think that additional burden on hospitals for reporting that is already being provided is unnecessary.
Okay, thank you. I see Representative Mara has a question or comment. Representative Mara, you're on.
Thank you so much, Mr. Chair. So you are reporting, but you're just not reporting for the 340B by itself. Is that correct?
That's right. So there's nothing in the 340B statute that says savings must be go to these benefits. The statute says, or the program, HRSA, the federal agency that regulates the program, says the program savings need to help make scarce federal resources go further and support patient care in your community. By virtue, most of our hospitals are eligible for 340B because they're serving a disproportionate share of low-income individuals. And so the Medicaid underpayment that is being supported through 340B savings, the financial assistance policies that are being supported through 340B savings, the uncompensated care that is being supported by virtue of 340B savings, all of those things are made, hospitals are able to provide those in part because of the 340B savings. But as I noted, a survey of 340B hospitals saw that about $9 million in program savings every year for a median dish hospital across the country.
But I'm just a little confused. If you got a grant, a federal grant, you would report like how much you got on a grant. So why isn't that you don't, what is it that's keeping you from reporting the funds just by transparency, just sure. So people
Yeah.
can see how much you are getting from that particular entity.
Sure. So one, there is no federal dollars at play here. These are discounts required to be made to these covered entities from the manufacturers. The discount ranges from 13% to 23%, dependent on whether it's a generic drug or a branded drug. Again, the program, the difference in what we would have had to pay versus what we did pay goes to all of those things that I described. No federal or state dollars in this case are at play. So it's different than a grant in that someone may be providing you with those specific dollars.
Okay. Thank you. Thank you, Mr. Chair.
Thanks for the question.
Thank you. I just wanted to follow up. You made a comment that the savings are not supposed to go towards benefits for the community, and that's not in this bill.
No, the savings are intended to stretch resources of the hospital to provide those types of benefits, Medicaid underpayment, community benefits. I'm sorry if I misspoke.
Yeah, okay. That's very helpful. I'm just going to make a comment. I know that the hospitals feel that they are going through financial challenges, and part of the reason is the Medicaid reimbursement is not enough. There's a lot of patients with no insurance that are being managed, and Medicare reimbursements don't make you whole by any stretch. And there's a small percentage of commercial insurance, which requires a very significant amount of infrastructure to make ends meet. But that gives you some benefit. So I do think that the hospitals, if they were to share what they make and what they lose, that would help clarify this opaqueness that is felt by many policymakers. And that's why some of the bills seem to be unfriendly towards the healthcare system, because it appears that there's not enough transparency. And that's part of the challenge that broadly the hospitals will have to deal with going forward. I just want to put that as a comment. I know it's easy for me to make a comment, but it's more complex with some of the expectations of the healthcare systems for compliance between federal and state and so on, and also the healthcare workers challenges that you have. So more information is sometimes better, and then we can start to look at how we can be more helpful as a state as well.
I appreciate the comment. I would respectfully submit that hospitals provide quite a bit of information both to the federal and state governments related to our finances. And as far as underpayment goes, in 2021, underpayment was approximately $993 million, with Medicare underpayment just over $1 billion. So there is quite a bit of information related to hospital financial performance and some of the places where reimbursement is not keeping pace with cost.
Okay.
I appreciate the comment.
I think Senator Gordon has a question or comment. Senator Gordon.
Yes, thank you, Mr. Chairman. And Mr. Kidwell, thank you for your testimony. And I've read through and listened to the Connecticut Hospital Association's testimonies. Just a couple of questions for clarification. I know the 340B program is a little over 30 years old. It was back in '92. I think the first President Bush signed it into law as part of an overall veterans healthcare bill. But my understanding is when you mention about bundling, which I understand very well, was your testimony, and through you, Mr. Chairman, if I may ask this question, was your testimony that because of bundling of medications, it's difficult to break out the 340B drugs from the non-340B drugs? I just want to make certain I was hearing what you were saying about bundling. I know what bundling is, but I just wanted to understand what you were saying about that can't be broken out, or it's just very time consuming to break.
I think it would be significantly challenging to break out those specific costs specific to certain drugs and when they were purchased. As you know, the discount when we buy the drug is certainly sometime in many instances before the drug might be administered to a patient. And again, the 340B program is not a patient discount. It's the savings of the program provided by the federal government are to allow those covered entities to stretch those federal resources further than they otherwise would if they had to pay the full pharmaceutical price.
And just a quick follow-up question, Mr. Chairman, and I understand that, and I know in some bundling situations, such as with chemotherapy, sometimes ancillary drugs that we give, like Benadryl, Tylenol, those you can't charge for. They're just all consumed up in a bundling fee, and it's almost impossible to break out certain things as far as what was costing what. The other question I then have is for 340B, I understand, about that it's required for certain manufacturers to, as defined by the federal government, especially through its Medicaid type of formulas, to have to provide drugs at certain discounts, some of them very, very significant discounts. Am I correct that the program does allow that if you provided a 340B drug to a fully insured patient, for example, with private insurance at a hospital, that you could actually get reimbursed the full market price of that drug and thus make a profit off of the 340B drug? Thus, it's just not a cost savings with purchase, but also a potential benefit for revenue. I'm not saying that happens with every single drug, but there are some people who do could get 340B drugs potentially, or have, and yet be fully insured, with a private insurance. Is that still happening? In what degree?
Sure. So again,
does that happen?
Yeah. So the definition of a patient is not specific to your insurance status, but is specific to your relationship with the covered entity. So 340B drugs can be dispensed to those individuals, those patients, as defined by the federal government, that have a relationship with the covered entity. Certainly there are, however, provisions to ensure that because manufacturers are also providing the Medicaid program with discounted drugs, that there can't be duplicate discounts. So the manufacturer is not required to both provide a discount to a Medicaid beneficiary and then also through 340B.
And just one last quick question, Mr. Chairman. So is your testimony then that a lot of this data that's being asked for is already available, or that it could be made available, just would be very time consuming and difficult to really parse out and provide in a certain time frame? Thank you, Mr. Chairman.
I appreciate the question. HRSA certainly audits 340B covered entities. The Health Resources Services Administration, which is the federal organization that runs the program, audits 340B programs, 340B covered entities to ensure that they're compliant with federal requirements. It is a federally regulated program, after all. Our testimony is that the requirements here are time consuming, and frankly, much of the information is already available in other places.
Thank you. Thank you so much for your testimony. Seeing no other questions or comments, we appreciate your testimony and your time with us today.
Thank you very much.
And we are going to go back to Ms. Vanessa Hanneman. Welcome. You can start from the beginning.
Okay, thank you very much for your patience. My name is Vanessa Hanneman, Chairs Anwar and McCarthy, members of the committee. I'm representing the Association of Surgical Technologists. AST is a national organization that represents more than 50,000 surgical technologists, whose primary purpose is to ensure that surgical technologists have the knowledge and skill to provide high-quality patient care. My testimony is supplementing written testimony submitted by Jonathan Brown, the president of the Connecticut chapter of AST, who works at St. Vincent's in Bridgeport. AST thanks you for the opportunity to testify in favor of Section 1 of House Bill 6835, which sets minimum education and certification standards for surgical technologists. And we really appreciate the inclusion of this language in House Bill 6835. AST was officially incorporated as a nonprofit association to ensure that surgical technologists are educationally prepared to deliver high-quality patient care, accomplished through accredited surgical technology programs, national certification, and continuing education. We have submitted a proposed amendment through our written testimony to address concerns we have addressed over the last few years, working closely with Connecticut surgical technologists, the Connecticut Hospital Association, and the Department of Health. Our amendment is identical to the amendment submitted by the Connecticut Hospital Association. So we're all in agreement. The amendment would provide for several grandfather provisions to ensure that there is no worry about anyone currently practicing being left behind as the new requirements are put in place. The amendment allows time after graduation for new surgical technologists to get certified. It grandfathers in currently working and experienced surgical technologists, as well as anyone hired before October 1st of this year. It exempts people who have received similar training in the military, exempts other trained individuals specifically designated by the healthcare facility. The amendment also adds subsection C to be perfectly clear that this legislation is not meant to affect anyone's scope of practice or restrict anyone working within the scope of their license, nor affect any students or interns who are under supervision. And then finally, the amendment clarifies that no administrative function is being placed on the Connecticut Department of Public Health. It simply allows the department to request proof of compliance if the need arises. So we strongly support Section 1 of House Bill 6835. And thank you so much for your time, and I welcome any questions.
Thank you so much for your testimony. And we are not seeing any questions or comments, but we are going to look at your testimony and make sure that we follow up on that.
Okay, thank you.
Thank you. Next on our list is Jennifer Duran. Ms. Duran, you're on.
Hi, good evening. Dr. Jennifer Doran, President of the Connecticut Psychological Association. It is late. I know everyone is tired. I will be as brief as possible. I'm here on behalf of the Connecticut Psychological Association to convey our strong support for Section 3 of HB 6835, which is a language adjustment to the public health statute that would grant psychologists the right to apply for retirement status when we choose to stop working in the field. I am thrilled to be a psychologist. I love my job. I love what I do. I do hope to retire one day. So the issue is that the way that it currently stands, we are listed on the Connecticut Department of Health website as either having an active license or as having an inactive license due to non-payment. The way that psychologists currently retire is we stop paying our licensure fee and are then listed on the website as, in unpaid status, which is of really grave concern to those in our profession. This is perceived as an embarrassment, that there's no option to say you're retired. There's no option to be listed as retired. It is really, hopefully, a quick and simple fix, and one that would be very, very meaningful to us, is having that option to apply for retirement and be listed that way. Also very confusing for the public to see a status like that and not know if a provider that they see or saw is still practicing in the field or not. It is very difficult to get licensed in our state. We've talked a lot today about access to care issues, right? That has kind of come up in different ways throughout the day. We have an access to care problem. It's getting worse. A Connecticut license is viewed as unattractive for a variety of reasons: cost, time to get one, et cetera, et cetera. I think this is one small thing we can do to make it easier and more attractive to people in the field who have a choice about where to get licensed. So there's more to say. We submitted written testimony, but I will stop there for now.
Thank you so much. Representative Kristen McCarthy-Vahey has a question or comment for you, Ms. Duran.
Hi, good evening. Thank you for staying here with us and for your testimony. And I'm hoping that we can do this. I think one of the questions that has come up a few times is about the money part of the section. And the question has arisen as to why the need for the fee. And my understanding was that was part of what came in through your organization. I wondered if you could speak to that and either disabuse us of that notion or explain.
In terms of paying for the retired status?
Yes.
Yeah, I think that is fine. We don't have a strong objection to it if that's what is required. Again, our members, especially our senior members, really just want the option to kind of retire with dignity and, be listed that way and be viewed that way by the public. So there are no strong objections on our side to, paying a fee. I think similar to what other professions do to officially apply for that retired status. We're happy to do it however it makes sense.
Thank you very much. I appreciate your answer. Thank you, Mr. Chair.
Thank you. And Senator Gordon has a question or a comment. Senator Gordon.
I do. Thank you, Mr. Chair. I appreciate the testimony. I would posit that if a psychologist wants to retire, that's good. I hope someday I might retire being a doctor. And it's fine if you want to submit an application or some testament to DPH or whoever to say, I'm retired. I don't see why there should be any fee attached to that. I have no idea what DPH would actually do that could justify $50, even $1. And so my comment is that if this committee wants to look into the wording, I would say it should be $0, because I see no reason that a psychologist who wants to retire after hopefully a long and successful career should have to pay any money to DPH for the privilege to retire. So my comment is it should be $0 unless DPH can specifically justify how it's going to use that $50 other than it just goes somewhere into the general fund. Thank you, Mr. Chairman.
Thank you. Mr. Rand, do you want to respond?
Thank you. Yeah, no, I appreciate that very much. I will say our license is significantly more expensive than neighboring states, which is a part of the issue. So I, of course, agree with you. We pay more than double what our colleagues in other states pay for the privilege of a license. So I support that and I appreciate that comment. Thank you very much.
Thank you so much. Seeing no other questions or comments, we appreciate you being here with us. And I will go back to number 70, Mr. Wilbur Nelson. I think you have audio only option. So for some technical reasons, so you're welcome to go ahead and unmute yourself and you can testify. Thank you for your patience with us. Welcome. Mr. Nelson. Going once, going twice. And we'll move on to the next person on our list, which is number 74, Ashley Van Meter. Welcome. You're on.
Thank you. Unfortunately, somehow my camera is not working now, but I just have a few comments to make. My name is Ashley Van Meter. I'm with the Association for Accessible Medicines, the generic and biosimilar manufacturers. We just had a few comments as far as we've worked with NASHP that I know has submitted testimony and other organizations over the years to ensure that there is a good amount of transparency in Connecticut. For example, the law that was passed about 5 years ago for transparency to ensure that, drugs are not taking inappropriate price increases. Generics on whole have saved Connecticut in the billions each year. And we just have some concerns with some of the provisions that we see that we think there might be some unintended consequences. So we would urge the committee to continue working with us on some of those provisions, specifically some of the transparency provisions, and potentially there are other bills on the affordability board and those sorts of things we think is a good way. We worked in 26 other states to help bring those sorts of things to fruition. Also, it's really important to not necessarily treat generics and brands the same because our markets are so drastically different. On the portions that discuss, for example, the part about pharmaceutical representatives and the types of reporting, there's no difference noted among brands and generics. And it's really important because generics do not have those sorts of representatives. We don't detail our drugs like the brand pharmaceuticals do. We don't have commercials. And so there's some of those provisions that will still require us to do the same reporting, even though we don't do those sorts of things. So I think some of those things need to be addressed. And so we just would ask to continue working so that the appropriate amount of transparency and that you actually get the cost savings that generics are always offering in the state of Connecticut and everywhere else. And I'm happy to answer any other questions.
Thank you so much for your testimony. Do you have a written testimony that you have submitted?
I can submit, I do have something written. I can submit that for you. Also on other provisions that we've seen suggested so that you have our comments on each of those.
Right. That would really be helpful because we're getting warm and ready before now we're sort of dwindling down in our capacity to understand some of the things. So with that, if you can actually send us anything written, that would be
okay.
All right. And we will get one more last try to Mr. Wilbur Nelson.
Okay.
Thank you so much. No other questions or comments for you, Miss Van Meter. Mr. Nelson. Mr. Nelson, Wilbur Nelson. All right, I think that would bring us towards the end of our public hearing. I just wanted to thank a number of people. I wanted to thank Beverly Henry, Kate Hamilton, and our LCOs, Eileen Lawler Parker, Nicholas Panzarella, our OLR team, James Orlando, Nicole Doobie, and also David Kaplan, who's been texting and coordinating things. And Dave Ratcliffe, who's been helping us out, Kathleen Panazza for keeping us on target and keeping us in 3 minutes and 5 minute messages, and CTN team, who's been keeping us on track as well. And our intern who refuses to go home, Piotr Kolokowski. Thank you so much for all you're doing, and Jinkoya for that. With that, our public hearing is completed. Thank you, everyone. Great to be here with you. And this is now close to 10 minutes short of 10 hours. Thank you. Stay well. All right. Thank you.
We did it.
We did it. Yeah, I know.
Well, I did, you know what? I did kind of want to ask her questions, but I thought you all might like.
You
have
attack.
something to say about it. If I did, yeah.
Oh, you're
Well,
gonna jump on it.
She was also driving.